so much, Phoenix. And, Phoenix was one of my early and one of my best fellows. So it's still, and now I get, now I get to be her boss again. So it's fun to see full circle. And I'm honored and privileged that I made the cutoff, right? AWE has a few good men, and so I made the cut for that. Thank you. All right, so recent advances in endoscopic treatment of GERD. These are my disclosures. So there's a growing number of endoscopic tools to treat GERD, TIF, GERD-X, ARMS-P, ARMA-P, MAZE, WRAP, and I hope in 14 and a half more minutes to give you updates and figure out when and how to employ some of these new tools. Maybe one way is to look at these endoscopic approaches in terms of their mechanism of action. So starting with TIF, TIF accomplishes an esophagogastric plication, where ARMS and ARMA is really mucosal resection and ablation, which is a scar-based strategy. And then we have a list of what I would call gastrogastric plications, which plicate stomach to stomach. Let me also ask the question for us to consider: when should we use endoscopic anti-reflux approaches? Of course, in the normal anatomy, that's important, but I think endoscopic approaches are very effective in patients who have altered anatomy, where other traditional surgical options may or may not be possible. So in choosing the correct tool, I think it really gets back to understanding the patient's anatomy and physiology, and that is the anatomy and physiology of GERD. And I've spent a good, solid, intensive 10 years really trying to understand this. And some of you here in the room are smarter than I am on this, but I think this is something that is so important for us to all be on the same page about. And that is our anti-reflux barrier is really comprised of two main structures, two deeply integrated valves, I say. One is the diaphragmatic crura, and the other is a combination of the lower esophageal sphincter, LES, and the GE flap valve. And I can go on for an hour talking about this, but to say the least, when we talk about the GE flap valve, it's such an intricate anatomic, physiologic structure. And our goal in anti-reflux procedures is ideally to restore the original mechanism and the original anatomy. So with that, I also want to caution us as we think about the endoscopic approaches to not neglect the diaphragm and the opening of the diaphragmatic crura. So I'm looking right at Missy D'Souza, one of our foregut surgeons, who will be quick to remind us that even without a hiatal hernia, if a patient has an open diaphragmatic hiatus, no matter what you do to the fundus by fundoplication, you're not going to get a good result, because with the diaphragm open, the beautiful valve that you create is just going to slide up and down and loosen prematurely. So this retroflex view with this bit of a cavernous opening, if you take that patient to surgery, they have an open diaphragmatic hiatus, i.e. that open space, if you had a laparoscopic view of that open space, equals that. That is the opening or the dilated diaphragmatic aperture. And again, this patient really should, if at all possible, get a crural repair, and then go on to also take care of the fundoplication. So we don't want to lose sight of the importance of the diaphragm as we think about the endoscopic approaches. The other thing is we look at the GE flap valve and reconstructing it. This is something that a number of us in the American Foregut Society are starting to pay attention to. And that is, we can feel really good about a fundoplication from the outside, but now we're starting to think about what does the surgical fundoplication look like from the inside? What does the endoluminal view look like? And is that important? And I think it is. You see normal anatomy with symmetry around the lesser curve. The door fundoplication has a anterior groove. The toupee, also not symmetrical, has a posterior groove. Nissen, and then TIF actually gives you a very symmetrical fundoplasty, fundoplication with a posterior groove and an anterior groove. So let's talk about TIF 2.0. The target is an endoluminal creation of a partial fundoplication that is 300 degrees in circumference, 3 centimeters in length. And getting back to the mechanism, it is an esophagogastric plication which increases the intra-abdominal esophageal length and truly restores the flat valve geometry. And this is something that we're really appreciating more and more. So on the left is the pre-TIF appearance, and on the right is the 1 year post, and in the middle is immediate post. So I call your attention to looking at the two images that are side by side, pre-TIF, post-TIF. Post-TIF, the flat valve is tighter. Post-TIF, the flat valve is longer. But other than that, it looks like the original valve, only longer and tighter. It does not look like an alien valve. And so that's the goal, to try to restore the flat valve. And this is a very different approach. Unlike a traditional surgical fundoplication where you're wrapping with some tension stomach around esophagus, this is just an umbrication. You're just dunking the G junction into the stomach and creating the valve through a traction umbrication technique. So there's been plenty of evidence. This is the early phase 1 evidence showing high efficacy and durability out to 5 years. This is a more recent paper of 85 patients undergoing TIF. And I call your attention to the subset of patients that we were able to create what we thought was a really nice TIF valve, meaning optimized 300 degrees and 3 centimeters in length. And objective pH testing, pre and post, showed that 94% of the optimized TIF patients had normalization of the acid exposure time. So this does tell us that technique is important and the way we create the valve is important. So what about long-term data? Now TIF has been around long enough that we can say we can follow and see the long-term efficacy. This study, systematic review and meta-analysis, followed patients out to 10 years and showed high efficacy and symptomatic control. This is another study, single center, up to 9 years, led by Reg Bell. Again, also showing very high sustained efficacy and the ability to come off and stay off PPIs, and this is by Reg Bell. Then what about combining an endoscopic approach like TIF with a surgical repair of the hernia and the crura? And we call this consecutive hiatal hernia repair plus TIF, or CTIF for short. Short-term outcomes, this is a recent multi-center prospective study looking at 188 patients and showing that CTIF, combining the two, had very high efficacy, patient satisfaction, and coming off PPI and normalization of pH. So this begged the question, if TIF seems so good, how would you stack that up against, say, the gold standard of anti-reflux surgery? How would CTIF stack up against Nissen fundoplication? So about 8 years ago, we started to design the prospective randomized study. We ran it for 6 years, waited for a year for all patients to get great follow-up objective. This is prospective randomized multi-center. And if you were at DDW, we presented the final results. So I'll share that with you. So this was led by Barham Abadaya. And again, it was a prospective multi-center study, blinded, CTIF versus Nissen. 164 patients were randomized, 68 randomized to CTIF, 64 randomized to Nissen. The primary endpoint was the quality of life, HRQL score, but secondary endpoints included going out to 12 months, normalization of acid exposure time, PPI discontinuation, and equally important on the efficacy side is what is the comparison on the downside, the side effects of these procedures, mostly talking about gas, bloat, and dysphagia. Would there be a difference? So I'm proud to say that in terms of the primary endpoint, absolutely no difference between the two arms. CTIF was as good, non-inferior to a laparoscopic Nissen fundoplication in terms of normalization and improvement of the GERD quality of life, and that was sustained out to 12 months. So objective pH testing is sometimes is not available in a lot of studies, but we were very careful to have that. So this looks at normalization of the acid exposure time as well as the Demista score, and it was completely similar between the two arms, no difference in physiologic testing with normalization in both arms of acid exposure time. And then we thought, well, maybe the patients with really severe reflux, LACD, they should do better with Nissen than CTIF. But again, no difference between the two arms in terms of normalization of pH and Demista, even in patients whose acid exposure time was 18%, they responded equally as well in both arms. PPI discontinuation at 6 months was 95%. PPI discontinuation at 12 months was 92%. Again, no difference between the two arms. So what was the difference? This is the only difference between the two arms. New onset dysphagia was significantly lower with CTIF. And that doesn't surprise us, but it was really great to be able to see this borne out in level 1 evidence. So dysphagia, new onset dysphagia was 32% with Nissen, over 2.6% with CTIF, and at 1 year, 28% versus 5%, significantly different. So what about long-term? We don't have long-term, but this is our single center data looking out over 2 years. And again, at 2 years, the great outcomes was sustained. In the brief couple of more minutes, I do want to talk about some of the other endoscopic approaches. GERD-X is now available in the United States, so you're going to be hearing more about it. So it's a dedicated suturing device. There are pledgeted sutures that are placed transmurally at the G junction. It's done in retroflex. You do need fluoroscopy to insert the device in. Each time it's a single fire. You need to remove the device, reload it, and then fluoroscopically guide it back in. And typically it's 2 plications, and it creates a gastric plication. It plicates stomach to stomach. So a lot of the anatomy physiology that we just talked about with TIF is not so much with GERD-X. And there have been some studies pulled together, and it looks like PPI use and symptom control is improved, but pH studies have not shown a difference with pre and post with this full thickness device. What about ARMS and ARMA? This is really catching on in Asia and parts of Europe and South America and coming to the US. So ARMS and ARMA, which was invented by my good friend Dr. Haru Inoue. ARMS is essentially doing a mucosectomy, doing EMR or ESD at the G junction, allowing that to heal and scar down and creating a tightness at the G junction. So it's really a scar-based valve augmentation. ARMA is using ablation, so APC ablation, and let that heal. And so it showed that ARMS seems to be effective, can help GERD symptoms. ARMA with ablation also seems to be effective. But then if you look at, and then the next iteration is ARMS P and ARMA P, where after you do your resection, you put clips in to close and create a bit of a plication. So now you're doing a gastric plication with clips. And ARMA P is doing ablation and then closing your ablation area with clips to create a bit of a valvuloplasty. This summarizes the data. So the symptomatic outcome seems okay. Durability is still a question, but you pay a price with more dysphagia, right? Because if your strategy is based on scarring and healing, it's a bit hard to control, and so you can overshoot and cause dysphagia in a number of patients, and then they'll need multiple dilations for that. And then long-term objective data is still pending. So we've also done a variation using mucosal ablation followed by immediate suturing. This is with the Apollo suturing device, and we call this MAZE, mucosal ablation and suturing of the G junction. And we've mostly done this in altered anatomy, patients post-esophagectomy and so on. And it seems to be helpful in patients with altered anatomy. We've also done quite a few of these procedures called RAP, resection and plication, where you do a submucosal injection, cap-based EMR resection, and then again using the overstitch device to create a valvuloplasty or plication, which then controls the scarring and healing and also gives you a valvuloplasty. So then how do you choose the right approach? And this is my last slide. Again, a very careful analysis, choosing the right patient, as Reina so well put it. And if the patient has a grade 3 or greater based on AFS or Hill grade with an open hiatus or there's a hernia present, please first think about surgery. And if the patient is a surgical candidate, they should have a surgical hernia repair with fundoplication, and that could be a toupee or it could be a C-TIF. If, however, they're not a surgical candidate or it's not feasible, then some of the endoscopic approaches, I think, would be fine. Now, if they don't have a grade 3 or more, if they have a grade 1, 2 Hill grade, and it looks like they don't need a hernia repair, then please consider the TIF, and it would work really super well. But if TIF is not available or somehow it's not feasible, then we can consider some of the other gastric plication techniques. So with that, I thank you for your attention.